Just about to get started. Okay, thank you for joining us today for our last webinar of the semester. So I'm delighted that we have Dr. Ryan Demmer joining us this morning, Associate Professor in Epidemiology and Community Health, received his PhD here in Epi in 2005. Then he was a postdoc at Columbia University. He joined their faculty before returning here. His main interest is on understanding the role of the human microbiome in the initiation and progression of cardiometabolic diseases. He's a PI or co-I on many NIH-funded cohort studies and interventions. Last spring, Dr. Demmer was appointed to Governor Walz's COVID-19 task force. And around that time, he embarked on his community-based surveillance study to understand SARS-CoV-2 transmission in healthcare workers. He presented that study design in his webinar last May, and today he'll describe the results and implications, and also his research on COVID-19 outcomes in the M-Health Fairview system, and finally some practical issues on the current state of SARS-CoV-2 infection tests. So Dr. Demmer, I'll turn it over to you.
Thank you very much. Good morning, everyone. Nice to be here with you on the brink of the holiday season. Happy Hanukkah. So as Mark indicated, today I want to talk about SARS-CoV-2 in general, give you an update on the healthcare worker study, talk about some work we've done in regard to cardiovascular medications and COVID outcomes, with emphasis on anticoagulation this time, and then say a few things about testing vis-a-vis the natural history of infection, and say a few words about what that means for potentially your holiday plans and beyond, because we're really moving into an era now where I think most people are going to have their own COVID testing story. Most people I talk to now have had to test themselves, or their family or close friends have gone through the ordeal, and there are just a lot of questions surrounding that. So we'll say a few things about that towards the end. It's a bit of a somber moment, unfortunately. COVID-19 has become the leading cause of death in Minnesota in recent days and weeks, which is really unprecedented, certainly in most of our lifetimes. It's maybe counterbalanced to some degree by a lot of excitement around vaccinations. Just this week on December 7th, the UK started administering the Pfizer vaccine, which is extremely encouraging for the world. And just yesterday, the FDA voted, an FDA panel voted to recommend the EUA authorization for use of the Pfizer vaccine in the US. And now the FDA will still need to make an official approval before vaccines can begin being shipped around the country. And the CDC has a committee that will need to make a final recommendation and then a CDC approval before we can actually start giving shots. But we're on the brink of vaccination in this country, which is remarkable. And it will have huge implications for how quickly we can get through this. So I already mentioned the outline. I'll jump through that and just get into it. I just want to start with some acknowledgements to a large number of people who have been involved in a variety of ways and really made a lot of the things I've been doing regarding SARS-CoV-2 and COVID possible over the last many months. I particularly want to call out Brianna, Ali, Angie, and Talia, who were involved back in March at the very beginning of the healthcare worker study, and it was just a feat that could not have been possible without their help and support. So I'm really grateful for them and the teamwork to bring this all together. And then also funding from the OVPR office has been essential to making this work. Minnesota Population Center has contributed funding. The Department of Health and CDC has also contributed significant funding. And the University of Minnesota's CTSI has been very impactful, and I'll say a few more things about that in a moment. So the initial goal of this study was to study symptom-free healthcare workers and essentially estimate the prevalence of SARS-CoV-2 carriage in this population, and then estimate the incidence of SARS-CoV-2 infection and COVID diagnosis over the course of the pandemic. And just a quick reminder for those of you that weren't here in the spring when I talked about this, keep in mind that when I'm talking about symptom-free, people can either be asymptomatic, where they're infected with the virus, but they never actually develop symptoms, or you can be pre-symptomatic, in which this is talking about infection that is prior to symptoms. So why do these things matter? Well, as we have learned, asymptomatic transmission or pre-symptomatic transmission, either one, is very possible, and it probably happens frequently. Early data showed that viral loads, which are shown here in this figure, are probably highest on average around the day that symptoms develop in people who go on to develop symptoms. And then viral loads start to drop off rapidly after that, and by days 7 or 14, viral load is fairly low again. And the implications for this, based on a lot of modeling, are that, again, roughly half of transmission probably occurs from somebody who doesn't have symptoms onward to the next infection. And infectiousness likely peaks a couple of days before symptoms develop. And this is just hugely important, and I think still not understood well enough in the general public, because it really speaks to why we're in the situation that we're in with this particular pandemic and this particular infection. People think that they're not infectious because they don't know that they're infected, and they're out and about and they're interacting with people and they're spreading. And we've seen many situations or events where this is the truth. Over the summer, we've seen a number of large-scale in-person gatherings where people are in close proximity without masks, sometimes indoors, but even outdoors in these settings. We know that this virus spreads if you're close to other people and you're breathing on them. And that has implications for where we're at right now in the fall. So with this in mind, early on, we had a good sense that this was the case, and we were really interested in healthcare workers because there was initial concern that they could maybe be keys in the infection chain or key individuals in infection chains. They couldn't stay at home. They were on the front lines of this. They were not able to socially distance, and they had to be at work and oftentimes treating sick patients with infection. So there was concern that they could get infected and pass on to other people. And coupled with that, there was a lot of fear among the public that they could be infected if they went into a clinic or a hospital for medically necessary treatments. There are some anecdotal reports early on, and more data, solid data have come out since, showing that emergency room visits, for example, dropped off significantly. These are data from a health system in California, showing that by mid to late March, ED visits had dropped off substantially, and these were of consequence. It was not simply the fact that the low-risk patients stayed home, but people who really needed to be in the emergency department got there. If that were the case, you would have expected in that setting that admissions from the ED into the hospital would have changed and gone up dramatically, but it didn't. It remained unchanged in that particular system. And at the same time, they saw EMS reported cardiac arrests increase by about 50%. So people who had medically urgent healthcare needs were staying home, and many of them, unfortunately, were dying at home. And there are many other reports that have come out now looking at excess death, confirming these types of findings. Understanding what's going on in healthcare populations is really important from that perspective as well, to get the message out about whether or not you should be going into the clinic. Vaccination rates is another concern many people have had. So in Minnesota, among kids under 2, MMR vaccination dropped off notably in March as the pandemic was taking hold. It bounced back a bit, but it's remained below the 2019 numbers throughout. And as a consequence, there will be a number of kids who require vaccination going forward into 2021. And we know that has implications for population health. So to look at these things, we started a symptom-free healthcare worker study. The study population included healthcare workers, again, who were symptom-free, And they were broadly defined. We enrolled physicians, nurses, physician's assistants, nurse practitioners, but also lab technicians, people working in reception, administration, folks working in EMS on ambulance crews, et cetera. And we were looking primarily at the prevalence of SARS-CoV-2. And then over time, we monitored people for symptom development and eventual COVID diagnoses. Our target sample size at the beginning was 500 healthcare workers, and they came and they performed self-collected nasopharyngeal swabs, which was just remarkable. Getting this study started, in many ways, it was the simplest conceptually study that I've ever initiated, but it was the most difficult logistically in the COVID moment because supplies were scarce back in March and early April, and there was very little known about safety and how we could do this safely. So many of us were talking about how to approach this, and we decided that a self-collection protocol would probably work in healthcare workers, and it did end up working quite well. And I'm just, I continue to marvel looking back at the fact that nearly 500 people came in and willingly swabbed themselves, which is not necessarily an easy thing to do. I did it to myself several times in the planning for the study. And it's a bit uncomfortable, but people came in selflessly and participated in this study, despite the fact that there was some real discomfort. And I wanted to say thank you to the CTSI again, because they allowed us to use their van, which I'd always been sort of a lifelong dream of mine to drive this van. And I got to do that and go around to a couple of different clinics, and eventually, through cooperation with many partners at the university, we were able to set up drive-through testing at WBOB and Moose Tower. So I could set up in the van and people would just drive up, do their testing, and be gone in about 2 minutes. And it just worked incredibly well. So a big thank you to the CTSI and all the folks who made it possible to use university resources to do this drive-through testing. We started with about 795 individuals who initially screened. Of those, about 80% ultimately consented to be in the study, and 489 turned up for an NP swab. And then a subset of those completed a questionnaire about the nasopharyngeal swab in terms of its acceptability and how well they thought it worked compared to swabs they may have done in their own practice. And I should note the data I'm presenting were just accepted for publication in infection control and hospital epidemiology. So those will be available shortly online. We conducted the study between April 19th and June 24th. So as you can see in the background, we have the Minnesota infection curve, and we captured the first wave. Our enrollment window captured the peak early on. People who were enrolled were 41 years of age on average, ranging from 25 to 64. 84% were women. And in terms of comorbidities, 14% reported a history of asthma, but otherwise comorbidities were fairly low in this population. It was generally young and healthy. So who were these folks in terms of their role in the healthcare setting and the types of healthcare institutions they were working at? 14% were physicians, and solidly half of them were nurses, with another 12% being physicians, assistants, or nurse practitioners. And then about 18% reported other. So these are folks who might have been in administration, reception. We had some members of janitorial staffs participating, lab technicians, and positions of that nature. So folks who are within the setting, some of them having some patient interaction, particularly in reception, but the vast majority of individuals were clinicians who are working with and treating patients. And in terms of the setting, 28% were coming from inpatient non-ICU workspaces, 19% were working in ICUs, a lot of them in the COVID ICUs in the metro area, and 15% from emergency departments. About 20% came from ambulatory clinics. A lot of folks in this setting were doing web medicine or telemedicine at the time, or they had the ability to screen people and they were doing more drive-through testing. So there was still patient care, but at more of a distance in that particular group. Overall, 40% reported known or suspected COVID-19 exposure in the last 14 days. And this question was asked on the day that they conducted their NP swab that was eventually tested for SARS-CoV-2. And those exposures, of course, were much higher among people who were working on ambulances or in the emergency department, also quite high in the ICUs. And then it dropped off a fair amount among individuals in the inpatient non-ICU settings, the other settings, or those in an ambulatory setting. I see a quick question here, since it's very relevant to what I'm talking about now about recruitment and how essentially did we approach participants for recruitment. So this was a convenient sample. We were working with limited resources and time. And quite honestly, my sister posted something that a university article about the study to social media. And in about 2 days, we had 800 emails that we were sorting through. And that's really how we recruited people for this study, was through social media. In terms of personal protective equipment use overall and by COVID exposures, the vast majority of individuals had some PPE, and I'll break that down in a moment. And among those who reported a COVID exposure, basically everybody reported having access to PPE at this point in time. PPE was in short supply and difficult. I talked to a lot of people anecdotally as they were coming in and doing their testing, and they were stretched thin and they were reusing a lot of PPE for sure, but everybody had something for the most part if they were in a setting where they were seeing patients in person. This is what the PPE breakdown looked like, and people could answer more than one, so some of these proportions would total to more than 100%, but the vast majority of people were using a surgical mask. Some reported an N95 with surgical mask over the top, and others just an N95. There were some face shields. Usually face shields were reported in combined use with some sort of masking approach, but very few PAPRs. And again, if you had COVID exposures, nobody reported having no PPE in that setting, which was encouraging. So the big question, what was the actual prevalence of SARS-CoV-2 in this population? And it turned out that it was 0. Which by the time we got to testing the samples, we anticipated that it could very likely be 0. And to speak a little bit more to what this actually tells us about SARS-CoV-2 prevalence in that population when you have a value of 0, let's look a little bit to our initial power calculations. So this graph shows the probability to detect at least greater than or equal to 1 positive case, assuming no measurement error, and that's on the y-axis, for a given true prevalence, which is on the x-axis. So on the far right, if the true underlying prevalence of infection in this group was 1%, we essentially had perfect power to detect at least 1 positive case. And that was true all the way down to about 0.7%. Power was very high, and even down to maybe about 0.5%. We were above 90% power. And then things start to drop off very rapidly. And when you get down into the 0.1, 0.2, 0.3% prevalence, our power was quite low to detect at least 1 case. And this is under perfect situations. It doesn't account for the fact that the sensitivity of these tests is not perfect. It was good, but not perfect. Okay, so what we could conclude is that it's very probable that the point prevalence in the sample was at least less than 0.5%. So how does that comport with data at the time in Minnesota? These are the 14-day case totals per 10,000 in Minnesota from April to June during the same time period that we were enrolling. And this is the 0.2% mark, or 20 per 10,000. So on average, even in the 7-county metro, we were probably below that in the general community. And if rates in healthcare workers were somewhat comparable to the general community, we would not really have had any power to detect positive cases. And that's okay, because when we went into this, we were concerned that there could be rates of 1, 2, 3, 4%, which would be much more meaningful in terms of transmission and risk. When prevalence was this low, combined with PPE, there was less concern. And at least in this type of sample size, we at least got a cursory view of what we thought the prevalence might be. Just as a quick note, if you haven't been watching the infection curves lately, so this is when we enrolled people, and this is where we are now. So we have, just blown past the numbers that we were able to sustain through the spring and most of the summer and early fall. So how do these rates compare to rates in other places? We wanted to think a little bit more deeply about how likely it was that the rates were really this low in the sample. Well, the Department of Health in September did a study in a community setting where rates were roughly in that 0.2 to 0.3%. They enrolled 642 individuals and none of them tested positive, so a very similar result. And the same lab that did our testing used the same test in 10,000 individuals in California, where the lab is located at UCSD, and they found a prevalence of 0.3%. So these things taken together give us reasonably good confidence that our test was good, our sampling approach was good. It's just that the rate in this population was quite low. So after the NP swab, then we started looking at response rates to biweekly, or we started conducting biweekly surveillance for infection and asking about symptoms. And these are the response rates, and I show them just because I find them to be very remarkable. Anybody who's tried to do survey research and repeated surveys over time knows that it's very difficult to get good response rates. But the participants in this study have just been amazing and continue to allow us to survey them. And over time, we were for many months over 90% in our response rates, and we still remain at about 80% or above. This last survey is a little bit lower because we haven't completed the follow-ups yet. Some people haven't come to their 12 survey time point. So that's fairly remarkable. And through those surveys, we asked about positive PCR tests or any sort of COVID diagnosis. And over that time, among people who presumably had not been previously infected, we don't know that for certain because we don't know, they could have been infected before they came to the study and recovered. But assuming that they were infection-free at baseline, the cumulative incidence in this group via self-report is about 5%. So moving forward, we just initiated a seroprevalence study funded by the Department of Health and CDC. We're grateful for that funding. The kit that we're using is on the right, showing the components. We didn't send them a ping pong ball. I just threw that in there to give a little bit of scale, but there's a lancet, some disinfectant instructions, a biohazard bag, and then this clamshell that contains the actual sampling device where the blood spot goes. And how this works is people prick their finger, and then they use this technology, a volumetric absorptive microsampling approach that just sucks up the blood into this tip. Participants close up the clamshell, drop it in the bag, and then drop it in the mail. It comes back to our central lab where we do antibody testing. The assay we're using is one developed by Quansis Biosciences. It has EUA approval. It's an IgG ELISA targeting the spike protein and has pretty good sensitivity and specificity, 95 and 99% respectively. And with these sensitivities and specificities, we expect about 1 in 20 positive results that we observe will actually be falsely positive at a prevalence of 5%. And about 1 in 33 positive results would be falsely positive at a prevalence of 10%. Okay, so this again is when we initially did the NP swabbing, and the antibody study is taking place starting over the Thanksgiving holiday and going into December. Our initial assessment was, plus or minus 3 or 4 days of the Thanksgiving holiday week. And then we're going to retest these individuals at the very end of December, so about a month apart. And this should give us some indication of seroprevalence from about mid to early August until the end of December in this population. So to date, we've consented 478 individuals. We did that in about 2 weeks. Of them, 252 have returned their sample and it has been assayed in the lab, and 19 were positive. So that's roughly a 7.5% prevalence, seroprevalence. And again, this is in and around the week of Thanksgiving. How does that relate to Minnesota numbers more broadly? Well, the best published data at the moment just came out very recently, right before Thanksgiving. And in Minnesota, seroprevalence obtained from residual bloods in hospitals was about 8%. Now that was back in September. So by Thanksgiving, you can expect this would have been higher. It's starting to hint that maybe we'll see lower rates, lower seroprevalence in this population than the general community. That's to be determined, but these are the best published data. And these are remarkable. So thank you to Dr. Yandel at the Health Department for sharing these results. They're conducting studies in conjunction with the Red Cross and a few other entities looking at blood donor seroprevalence. And you can see that early on, the blue dots correspond to the American Red Cross. And the seroprevalence here was around 2 to 3% through the early or the midsummer and early fall. And then look at this starting in the beginning of November. As you would expect with the infection rates going up, this is just a very steep and straight line, about 1 to 2% increase in seroprevalence per week. As of Thanksgiving week, we were close to 14%. Again, this is among blood donors. It's not representative of the general population. And I have no idea whether or not these would be over or under estimates to the general population. But regardless, the seroprevalence is definitely climbing. And in this population, again, much higher than what we've observed. So in conclusion from this study, we saw the prevalence of SARS-CoV-2 among symptom-free healthcare workers to be less than 0.5% in this sample. That's our estimate. It's unlikely to be an important piece of the transmission chain, at least when community rates are low. I want to make that point. We don't know what this means in the current context when hospitals are bursting at the seams. The transmission issues could be very different in that particular setting. I think avoiding medically necessary visits to healthcare providers is certainly not justified. People can mask up and call ahead. And if you think you need to be in the hospital, you should get there or at least call ahead and receive medical advice. And our initial seroprevalence estimates were about 7.5%. Appears to be lower than other Minnesota estimates, but it's really too soon to know big picture if infection is more or less common in healthcare workers, because we really don't have the full picture yet of infection rates from the very beginning of this until the very end. So we'll continue to monitor and hope to get answers to that question soon. Now I want to transition and talk a little bit about anticoagulant therapy in COVID-19 patients. We looked at outpatient and inpatient anticoagulation therapy and specifically the risk of hospital admission and death among COVID-19 patients in the M-Health system. And these are the co-authors who I'd like to acknowledge for their work and contributions to this. It's been a great team and a lot of fun bringing this together over the summer. So why did we do this? Several prior anecdotal reports hinted that there might be an increase, particularly in clotting related events among patients with COVID. And some early autopsy findings found fairly striking results that really suggested this could potentially be the case. I've summarized some of these findings here, but in a small autopsy study of 12 individuals who died from COVID-19 in Germany, they found 58% of those individuals had DVT present, and about 25% had pulmonary embolism as the underlying cause of death. There was significant elevations in D-dimer, a biomarker of clotting risk. And these individuals had noted that patients with COVID-19 who have increased D-dimer levels, a sign of coagulopathy, may benefit from anticoagulant treatment. And that seems plausible to them. So based on that early evidence, in roughly late April, mid-May, we started looking at this in the M-Health system. That system has 12 hospitals and 60 primary care clinics. And we looked from March 4th to August 27th at people greater than or equal to 18 years of age who had PCR confirmed COVID. We were able to get medication information from the electronic health records. And we specifically abstracted anticoagulation therapy along with several other medications that were included in multivariable models. We'll focus on anticoagulation therapy here. And for our outpatient analysis, we simply looked at prescribed oral anticoagulants in the 90 days prior to diagnosis and whether or not they reported there was evidence in the medical record that that had been prescribed, yes or no. We're also able to look at different classes. So we looked at DOACs, Coumadin, and Lovenox. And in the inpatient setting, we looked at individuals who were not using anticoagulants, those who initiated use upon admission, and those who continued their use. So they were on anticoagulation as an outpatient, and once admitted, that was continued per institutional policy. I'll note that by mid to late May, the institutional policy within the M-Health system changed so that all COVID patients were put on anticoagulation therapy. And I'll show some results related to that as we move forward, but it somewhat complicated our analysis because there was a change in protocol midway through. Our outcomes were hospital admission and death, and there were just too few specific event types for meaningful analysis by types of outcomes. So for example, it would have been nice to look at things like VTE or heart attacks and strokes, and certainly bleeding events, because there's risk that maybe bleeding events could go up if you're putting people on anticoagulation therapy. But fortunately for the patients, these events were quite rare, at least at the time of our analysis, and we couldn't look at in that particular fashion. Here's the flow chart. We started with a little over 7,000 patients during that timeline. About 6,000 ultimately had data that allowed them into our analysis. And overall, the hospitalization rate was about 15%. And hospitalization after initial outpatient treatment was 6%. The overall mortality rate was close to 3%. And among those who were hospitalized, the mortality rate was 13%. So patients were about 50 years of age on average. They were 10 years older on average if they were admitted to the hospital, and a slight majority were female, although females were less likely to be admitted. This shows the prevalence of various comorbidities that are of interest for COVID. So the most common comorbidity was hypertension. 35% of patients had hypertension. About 20% had at least one clotting associated comorbidity, a variable that was put together by our team, which really is sort of a summary of several, but not all of the different comorbidities listed on this slide. And then the most infrequent comorbidity was a history of heart attack, about 2.5%. In terms of risk for admission, these are just crude unadjusted risk for admission, because I think that's sort of an interesting thing to look at among people with certain comorbidities. If you have hypertension, your risk of admission to the hospital was about 12 or 13%. And people with a history of MI, the risk of admission was over 20%. All of these were significant univariable predictors of admission. And I'll say also that many of these comorbidities were also associated with increased anticoagulant use, as you would expect. There were 160 anticoagulant users in the outpatient setting. That's about 3%. We really didn't have sufficient numbers to do subgroup analyses by different medication classes, but results in that subgroup were consistent with the overall findings that I'm about to show. So these are the findings for anticoagulant use in hospital admission. And then in a moment, I'll also show death among about 5,500 outpatients. So the big picture answer for anticoagulation is that there was almost a threefold increased risk among people who had an indication for anticoagulation therapy. So some comorbidity that suggested they should be on an anticoagulant, and not everybody with an indication was on therapy. And for anticoagulation use, there was about a 43% reduction in hospital admission after multivariable adjustment for a number of comorbidities, age, sex, and race. In terms of predicting death, there was a trend for anticoagulation therapy to be related to lower death. It was underpowered, and it was a subtle 12% reduction in risk for death, but trended in the way expected, and no indication that there would be an increased risk. Findings were consistent by drug class, as I mentioned, and these are the results for anticoagulant use and mortality among inpatients and also among a subgroup of inpatients that had D-dimers. Early on, most folks who were admitted were not getting D-dimers measured. That changed over time as institutional policy changed, and then we were able to look at a subgroup that actually had D-dimer and to see what happened after adjustment for D-dimer. So in this analysis, We defined people again as whether they continued their anticoagulation therapy, they initiated, or they had never used anticoagulation in the full sample. We used the continuation group as a reference for reasons that should become apparent in a moment. And we saw that those who had never used anticoagulants were at about twice the risk of death in this particular setting. That was statistically significant. There was a suggestion of an increased risk for people who initiated, but it wasn't statistically significant. Part of the issue here is that in this analysis, we didn't have D-dimers on everybody, so there was probably some confounding by underlying risk, and the people who initiated were probably those who should have been on anticoagulant therapy at home and were not. And as a result, it probably wasn't the initiation that increased their risk, but just their underlying phenotype and risk for clotting. So in the subgroup where we could look at this with people who had D-dimers measured, we found that initiation was not at all related to adverse events. And we were, of course, unable to look at never users because this subgroup effectively includes everybody post-institutional policy change where all patients were put on anticoagulation in the hospital. And this just shows D-dimer levels by according to whether or not people continued anticoagulation therapy. They initiated at a medium or a therapeutic level, and it supports the underlying assumption that people who started anticoagulation therapy did have higher clotting risk upon admission, and maybe they should have been on anticoagulants at home. So in conclusion, from these results, we found outpatients using anticoagulation therapy had a 43% lower risk of admission and a 12% reduction in mortality, although that was not significant. Among hospitalized patients who never use was associated with almost a twofold increased risk of death, and no increased risk was associated with initiation. There were several limitations to this, which I imagine we can get to in the discussion. Many of these are limitations inherent in abstracting data from EHRs and from observational studies where there's a lot of confounding that can be difficult to deal with, but there are several trials that are ongoing that should resolve these limitations, hopefully, or at least mitigate them. And we hope soon to have more clear answers about whether anticoagulation therapy in the outpatient setting could be valuable. And maybe in the short term, we could focus a bit on getting people who are indicated for anticoagulant use to start taking them, because there does seem to be some benefit among people who become infected with COVID. Those who are on anticoagulant therapy, adjusting for other factors, seem to do better. They're less likely to be hospitalized, they're less likely to die. All right, so in the final about 5 minutes here, I just want to say a few things about testing. First of all, for a more in-depth view, I'd recommend that you go to the CIDRAP viewpoint. Angie Elric was the first author on this, and they have a nice article on smart testing that really sort of dives deep and talks about all the important issues that we don't have time to get to today. So I would direct you to that. As always, CIDRAP does a great job, and props to Angie for a very nicely led and written piece on testing. So there are now so many tests, and I want to just remind people what the main tests available are. At this point in time, everybody knows this sort of common knowledge, I think, because it's been in the news so much. But so we're all on the same page. There are really three different types of tests. The PCR, or the molecular test, measures whether or not you have current infection. These generally take time. So in very rare settings, you might be able to get a result in a few hours if they have a lab on site. But most people, it is taking several days to get your results back if you receive a PCR, also called a molecular test. Since we talked in May, antigen tests have started to come on the market and be used in much greater numbers. This also is a measure of current infection. Many of them are rapid tests. So if you get a test back or a result back in about 15 to 20 minutes, it's almost certain that you had an antigen test. And then there are antibody tests, which generally test for past infection. There's some very rare clinical situations where they're being used to determine whether or not somebody might still be dealing with a COVID infection, but that's quite rare. And in general, antibody testing is still not really recommended for the public. It's more a research tool than it is a tool to really understand if you're infected and to make any decisions at the individual level. So where do we stand in terms of the number of tests? As of May 1st, when we talked last, there were about 45 PCR tests available. There were no antigen tests that were EUA approved. And I don't think there were any EUA approved antibody tests at that time. But if there were, it was very few. This information is not clearly published by date on the FDA's website. So currently, we now have over 200 PCR tests. There are 8 different antigen tests and at least 63 antibody tests. So as predicted, we have all of these tests with very little coordination in terms of what they mean against each other and who should be using them and when, or any sort of standardized scheme in terms of pricing and what these tests should actually cost, what they cost to produce. So I wanted to, with that in mind, talk a little bit about the natural history of infection in relation to testing, and then kind of tie that back into the notion of gathering and whether or not people should be gathering with family and friends. So as a reminder, when you're initially infected on day 0 here on the left, and thank you to Abbott for these nice graphics I'm going to use. I think that they put together some good graphics that summarize these points quite nicely. I'm going to make a few corrections to them as we go through based on my understanding of natural history of infection, and I'll make that obvious in just a moment. But when you're infected at time 0, you have an incubation period. For people who are going to develop symptoms, there's an incubation period between infection and when the symptoms begin. On average, that's about 5 to 7 days. It depends on the study you look at. It can be shorter for some people. It could be a day or 2, and for other people, it could take longer. But on average, it's roughly in the 1 week period. And as you get to maybe 2, 3, 4, 5 days out, viral levels really start to climb rapidly, and they become detectable by many of these tests that we just talked about. Okay, so that's the incubation period. And the one correction I want to make here is, at least in my opinion, based on published data, this peak should be shifted left and much closer to the date of symptom onset. So just keep that in mind as we go forward. The peak of viral replication and circulating viral levels should probably be shifted left to some degree. Over the course of infection, as viral loads rise, the virus makes antigens. These are just proteins, and they correlate very strongly with the actual viral load. The thing to remember about antigens, and therefore antigen tests, is that the antigen levels are slightly delayed relative to the actual viral RNA. And therefore tests that measure antigens are more likely to be falsely negative early on in the course of infection. And then antibody tests are looking several weeks out to several months out. They tell you whether or not you were infected, okay? So in this incubation period, most tests are likely to be negative, even if you're truly infected. In this stage, between roughly 1 to 2 weeks from infection and the first week of symptomatic infection, PCR tests and antigen tests are much more likely to be positive, but an antibody test would be negative. And then in the long term, the antibody tests are much more likely to be positive, but a viral RNA or an antigen test is likely to be negative. Okay, so again, right here, you're thinking about, do I have it now? And in the long term, you're thinking about, did I have it in the past? And this is the period when you're most contagious. So what I want to point out here is, for people who are thinking about gathering with people or traveling for the holidays, or traveling because you need to travel, a question I'm often getting lately is, if I fly on day 0 and I get to my destination and I stay in a hotel for 1 or 2 days and then take a test and go on and stay with, for example, my vulnerable family members or friends, is that safe? And what's the recommendation? Well, what I want to point out here is that in this time period, just before symptoms begin, in a symptomatic individual, you're infectious. And the tests, both antigen and viral tests, are less likely to actually detect that and turn up positive. And this time period where you even begin to start having some ability to detect it is just a couple of days before symptoms begin, and probably 4, 5, or 6 days after you're actually infected. So if you fly and that's your potential exposure time period and you only spend a day or two in quarantine and then test in this period, even if you're infected, you're almost certainly not going to pick it up. Then you'll travel on to your destination, and during this period is when you'll be spending time with family and friends, which is when you're most contagious. So that's the thing to really be thinking carefully about in terms of gathering. If you must, you really want to probably wait at least a week and have a test, if not 10 days from your point of travel or your last point where you were not in a full quarantine. A couple of things of relevance about rapid antigen tests, because in this setting, most people want to do a rapid test so they don't have to wait a couple of days more in quarantine to get their PCR result. The Abbott test has pretty good sensitivity, according to some published data, within a week following symptoms. But in the week, if you're greater than a week from symptoms, the sensitivity drops off to 75%. And I haven't seen good data on symptom-free individuals. In some settings, I've seen reports of sensitivities less than 50% for this test. And again, you can go back to the White House example of situations where even with a lot of testing, using in some part these tests, infection rates can certainly surge. So should I gather with family friends? I guess the upshot for me is avoid it if at all possible. I say no, this is one year to avoid it, especially at this moment when rates are so high everywhere. Some people don't have a choice, and they need to travel and they need to be with people for a variety of reasons. So if you're in that boat, the best recommendations I can see come from the CDC, and these tie and couple up very nicely with the graphs and figures that we just looked at. And effectively, the recommendation would be make sure you're in quarantine for at least 10 days from your last point of contact with anybody who could have been infected. So if you travel on a plane, quarantine for 10 days, make sure you have no symptoms developing in that point in time, and then any sort of risk of residual transmission is quite low. Modified recommendations would say 7 days of quarantine and a negative test and no symptoms. But even in that setting, the transmission risk is still estimated to be around 5%. So these are some guidelines one could use if you absolutely must travel. But again, I'm not making a recommendation for sure that people should just travel and use these. I think people should stay home this year, keep your group small to people in your household. But for those that have no choice, this is, I think, the best evidence that you could use to make reasonable decisions. And I'll stop with that for discussion with some quotable quotes for COVID-19 in honor of the late Alex Trebek and our own Dr. Lind, who was recently a contestant on Jeopardy. So thank you all very much for your time and look forward to the discussion.
Thank you, Ryan. That was fantastic. There's a number of questions. I assume you're comfortable just picking those.
Yep, I'll start looking through. I saw them start popping up and I knew I wouldn't finish if I answered on the fly. So did we survey via smartphones? It was not explicitly via smartphones. We used RedCap and deployed that way. So the surveys were sent to email addresses, not to cell phones. And they could answer on a smartphone. Many people did, but they could also answer on a desktop. Any positive recall COVID symptoms? We haven't looked carefully at that yet. We just haven't had time to dig into the data. But we will look at symptomatology among people who did and did not report COVID and among people who will end up testing positive in our antibody study. BMI not on the list. So that's a great point. We just didn't have good data on BMI, unfortunately. It was an issue with the electronic medical records, and a huge amount of data was missing on that particular variable. So we opted to keep it out. Fortunately, or fortunately maybe isn't the right word, but we know BMI correlates with a lot of other comorbidities that we did have. So that's sort of our best adjustment for that. And similar issue with smoking. We just didn't have enough data on smoking. I actually haven't seen a lot of information or publications on smoking and COVID risk beyond adjustment for other factors like pre-existing cardiovascular disease and medications that you may be on. But no, unfortunately, we didn't have smoking, and that will be an interesting thing to explore as well. Do you think some people are simply not susceptible to COVID based on their cell membrane receptors and other aspects of the cellular biology? That's a good question. I don't have a great answer for it at this point in time. I would imagine that it's possible. There are some people who aren't all that susceptible, but I think looking at the rates that we've seen in almost any setting, I think the vast majority of people are susceptible, and to a large degree from a population health perspective, even if there's a small amount that are not susceptible, it's really fairly irrelevant at this point in time because the population toll of this pandemic will be so huge based on the fact that we know so many people are susceptible. I was talking with a group recently from a study in Brazil where they basically took the let it rip approach. And in that study, they estimate, I think 70 to 80% of people were infected. In most places, it seems that if you allow this to run its course without any sort of mitigation measures, the vast majority of the population gets infected. How did you define outpatients who should have been anticoagulated? Evidence-based, was it defined without knowledge of the outcome, hospitalization and death? So it was defined without knowledge of the outcome. That part is true. And the clinical members of the team sat down and came up with a list of comorbidities based on ICD-9s that they felt would merit an anticoagulation indication. Do you know if there are any state of Minnesota requirements for testing workers in long-term care facilities? Unlike outpatient clinics where contact with patients may be limited to 15 to 20 minutes, in long-term care facilities, that's not always the case. Yeah, great question. I don't know about requirements for testing in long-term care facilities. I know MDH had put together efforts to do testing in different long-term care facilities. So where they saw that there could be an outbreak, they were sending teams there to do testing to try and get it under control. But to my knowledge, there were never any requirements that testing be done. And early on, there was such a shortage of tests that it was hard to make any sort of requirement like that. At this point in time, we could probably move forward with some recommendations of that nature. I have a high-risk child. Do you have recommendations about what to expect of any childcare help that comes to our home? For example, expecting them to only stay with their own household, not care for others, etc. Yeah, that's a super tricky question. It really comes down to an individual conversation with that person and, asking them to try and isolate, because if they're not, they certainly raise the risk of the virus coming into your home. I don't have a great recommendation or approach or resource to recommend in this particular setting, other than what you're sort of alluding to here, which is just to have that conversation with your care provider who's coming into the home. Is a recording available? I'll defer that to Mark. I think they usually record these, so that should be available. And then the last question, do you have ABO blood type information? In the M-Health data, I don't believe they have it on most people, but I think they have some information. And Chris Tignanelli is the person who's leading a lot of these efforts. They have several papers coming out of M-Health, and they were looking at this. I'm not sure where it's at this particular moment. So I don't have a great answer to that. Sorry, Kamachi. So that was the last question in chat. Are there any other questions? Do people want to unmute and ask or share comments?
Yeah, Ryan, I was thinking about the question of susceptibility. There's been so much confusion throughout this pandemic about children, and it's related to the school at home or school as usual. What's the latest on their susceptibility, their ability to transmit this virus?
Yeah, great question. So kids definitely fare better once infected. They're much less likely to die. In fact, there's some data showing that young kids have lower mortality rates from COVID than they do influenza. So that's really good. They're less likely to die. They're less likely to be hospitalized. However, there are kids who are dying of this, and there are some particular syndromes in a very small proportion of kids who get sick. But this multi-system inflammatory syndrome that seems to really make some kids sick who are susceptible. Who they are and why that happens is really unknown. So, you know, the bad outcomes are less in kids. But to the question of can they transmit, from my perspective and data I've seen, I say absolutely. Kids are really important, and they're probably pretty good at transmission. There were early studies out of France showing that kids were bringing it home from the schools, and then it would move from schools into households. There were some reports from the CDC and MMWR this summer, one in particular from a summer camp in Georgia. One kid showed up infected to that, and by the time they sent kids home about 5 or 6 days later, about half of the camp had been infected, and then that probably had ripple effects to the households those kids went home to. So definitely high school, middle-aged kids are getting infected and transmitting. Younger kids are getting infected. They seem to maybe transmit a little bit less efficiently. So it's an important consideration, and it's so tough. I think a big part of our fall surge is that we sent a lot of kids back to school. It's not the only reason, for sure, but I do think it contributed. At the same time, my kids were in a hybrid environment, and we allowed them to go until about MEA before we pulled them. When we were starting to see our community rates go up a little bit, and we had one case reported in the school. So it's a tricky issue, but I think with really good masking and distancing, some sort of hybrid approach can work. But we have to get the community rates down to something a little bit more manageable before kids can be in the classroom, because I do think they get infected and transmit based on the current data.
Thank you. That's helpful. A hand went up. Diane?
Yeah, I see. I don't see the hand.
Can you hear me?
Yeah.
Ryan, thank you so much for your work and really for this talk. I have a question. So what do you estimate is the number of people in Minnesota who have actually had COVID? I mean, we know based on how many people have gotten tested, but I'm just wondering if you have thoughts on that.
Yeah, that's a great question. I would, at this point in time with the seroprevalence estimates, they're, you know, up close to 14%. Again, those aren't perfect community-based estimates, but that 14% is probably not going to capture everybody back to the beginning, and it's not going to capture all the infections that happened in April, May. So I wouldn't be surprised if we're approaching the 25% mark, somewhere in that neighborhood.
So you think 25% of the population in Minnesota across ages has had COVID?
Yeah, so that would maybe be, you know, 1 to 1.5 million if I'm doing the math right.
Okay, that's an important number to share.
Yeah, and that, you know, that's an on-the-fly guess. If I were going to do it more precisely, I'd look at the health department numbers right now, and I'd inflate that number by 5 or 10. Pick your number, but early on we were probably getting 1 case for every 10. It might have even been a larger ascertainment bias. Now we're doing much better, and the seroprevalence data suggests that we're probably getting between 1 in 4 to 1 in 6 people who are actually infected. So that would be another way to estimate ranges, to multiply current number of known infections by 5 and by 10, and it's probably somewhere in the middle.
Thank you.
Good question.
Would be great if you could squeeze these last two in, Ryan. One of them is on flying, so that'd be a good way to close it out.
Yeah. So I'm just looking through. Who is the maker of your blood spot test kit? It looks like it's taking more of our research projects remote. Yeah, Neoteryx, Neoteryx. Feel free to send me an email. I'm happy to share that with you, but they have a nice product, and they're working with Quansis so they can ship these out. And that was a great point. I mean, planning a study in a pandemic where you don't know what's going to happen is so difficult. We started planning this antibody study in May or June, along with Tim Beebe and Craig Hedberg and folks at the health department, and Becky Wirtz as well in our school. And it was really hard to find a good test that had EUA approval, or we thought would have EUA approval in time. And the bigger complication was this exact issue of what happens if things really start to spike in the fall, which we think they will, and we have an in-person protocol. Are we going to do all this planning and it all gets shut down? So we took a little bit of a risk early on. We went with a test that was under review for EUA approval, but it wasn't yet approved. But it allowed us to do remote testing, and we're very happy with that at the moment, because right now I don't see how we'd be able to do in-person testing if that's the protocol we came up with. And then one more question was, if a flight is your risk, why not fly in immediately prior to a gathering and leave within a short time prior to extensive viral replication? That's an interesting thought. I think the big risk there is that we're talking about averages in terms of the average incubation period. So there are some people, if you got a big dose, you know, you're walking to the bathroom on the plane, and we all know how that interaction goes when somebody's coming out and you're trying to get into the bathroom and they cough in your face. You know, there's evidence that those types of exposures can lead to worse infections, deeper infections, more viral replication more rapidly. So it's an interesting thought, but I think there's no evidence to suggest that that would be a good strategy. The better strategy is long isolation periods before you gather with anybody, particularly vulnerable people. Should seropositive people still get the vaccine? I think to be determined. We don't know enough about that yet. It's a great question. Starting off, yes, absolutely. If you're a healthcare worker and you've been infected, I think the evidence is that you should get the vaccine just to be sure, because your risk is high in the front lines. Mayo is doing a lot of studies right now where they're collecting PBMCs and whole blood so that they can look at reinfection rates among people and determine what kind of durable immunity exists from a prior natural infection. And therefore, if you could maybe put people who were previously infected at the back of the line and make vaccines available for others. So it's a great question. It's still to be determined. And in the short run, I think the best recommendation is that you should get vaccinated according to your priority without considering prior infection. That's the last question in the chat, Mark.
Yeah, we really appreciate you providing this last webinar. I think it was incredibly timely to share your results and your advice moving in. You know, we're in the holiday season now, so I hope we can all heed your advice and stay safe. This was the last webinar of the fall, so thank you for joining. And I hope to see you all in the new year, in 2021.
Vaccines are on the way. Thanks, everyone. Really appreciate it. Feel free to email if there are things we didn't get to.
Thank you.